Oh, good afternoon. This is a demonstration of cranial osteopathy. My name is Tony Bryant and I'm an osteopath, British trained, who is at present working in Auckland, New Zealand. And I'd like to introduce you to two concepts today. The first is of the fascia of the body, which are predisposed longitudinally in the body. And if you can imagine the fascia as a complete system containing envelopes for the muscles and the various organs, you will get an idea of the whole continuity of the fascial system, including the dural tube and the CSF, and this will give you a good base to look at cranial from. The second, of course, is the cranial sacral motion itself, which is a newly discovered physiological system with a steady rhythm of about 8 to 10 cycles in the normal person, which persists throughout life. And this is palpable on the cranium of the subject, and if I place my hands upon Kim's head here, I can immediately pick up the rhythm. And it's going into the extension phase at the moment. 2, 3, 4, pausing at the end of its movement. There's a little bit of release of tension, and then the cranium broadens between my hands and swells naturally into expansion, which is termed the flexion phase in cranial non-climature. Before I get onto the cranium proper, I am going to pay attention to the 3 or 4 diaphragms in the body: the urogenital diaphragm, the respiratory diaphragm, the thoracic inlet, and the cranial base, which are sites of possible transverse restrictions in the fascial continuity of the body. So in order to start, I am going to come onto the urogenital diaphragm, and I'm going to place one hand over the sacral base, extending from about S2 to about L4, and the upper hand comes over the suprapubic region just above the pubes. Now I'll produce a little bit of anterior-posterior pressure in order to relax the tissues, and now I'm going to take it into the position of ease, which is, in this case, towards Kim's left. So my top hand is traveling away from me. I can feel the end of the excursion of movement coming up now. There is a very nice release of tension. And now I'm going to come up to the thoracic inlet. My upper hand is over the C7 and about the first 3 thoracic vertebrae. The upper hand is on the upper sternum, a manubrium area. I'm giving a little bit of anteroposterior compression, and as I do so, I feel the tissues release. There's a kind of unwinding movement there. It's a passive and waiting technique, and I'm just holding the head like this and waiting for a softening of the tissues. Certain discrete areas of tension will reveal themselves as bands of longitudinal tension running off the base of the occiput. As they do so, I will shift my fingers in order to put the pads of my fingers right in the middle of those tension areas, and Kim has one tension area about 2 centimeters away from the midline underneath my left hand, and I'm just moving my left forefinger to really take out that particular restriction. And her head is coming up rather like a cork out of a bottle. There's quite a lot of cephalad movement there. And now I'm satisfied that the AO area is released. Now I'm going to come on to the cranium proper, and the first area I'm going to pay attention to is the motion of the sphenoid and the occiput. And the sphenobasilar articulation is right here, just in front of the foramen magnum. It's subject to many movements. The main one is flexion and extension. I will adopt a vault hold which is like so. So as I'm feeling the extension phase now, I can feel my thumbs on the greater wings travelling anterior and slightly cephalad, while my fingers monitoring the movement of the occipital base are travelling cephalad also. Take up a position with my right thumb on the left great wing of the sphenoid and my right fourth finger on the right great wing of the sphenoid, and I'm going to take it into the position of ease. But it appears as if it's a direct movement, somewhat like the carriage of a typewriter. So I've noticed that there is a restriction toward the left. Therefore, in cranial nonclimature, this is named as a right lateral strain. Sphenobasilar compression. In all of the previous moves, the flexion and extension activity have continued. In the compression, flexion extension is severely restricted, especially the flexion phase. There may be almost no flexion at all and a very limited extension phase. If that is so, the patient is very often emotionally depressed. I might lean my body forward with the elbows extended in order to get better proprioception. I'm lifting the greater wings of the sphenoid in order to lift the sphenobasilar articulation upwards or anterior, and as I do so I can feel a considerable unwinding of the occiput, and now I have covered most of the movements of all of the movements of the sphenobasilar articulation. Having done so, it becomes apparent that there may be certain restrictions either at the temporal sphenoidal area or the temporoparietal sutures, in which case I would do a V-spread technique. Now the next area I'm interested in is the movement of the temporal bones, and the temporal bones rotate about an axis which goes through the middle of the external auditory meatus, and I will do this until I feel the temporal bones are facilitated in their movement, and one of them will pause, wait for half a cycle for the other side to catch up, and then they will go in synchronous motion. To test the rotational component of temporal movement, I would adopt a position like this. What I'm interested in is the parietal lift, and I'm producing a very gentle cephalad traction. The next area I'm interested in is the frontal bone. My concentration is totally on my thumbs as they lift the frontal bone anterior. In cases of rhinitis or sinusitis, by placing the fingers on the upper orbit, occasionally I will get problems with the maxilla, with the zygoma, and the zygoma rotates around an axis roughly from the angle of the jaw to the glabella. It's a very nice movement and provides considerable relief to the patient if performed properly. It's a very, very effective relaxing maneuver. Okay, now this, except for the CV4, is covering all the movements in a routine cranial examination and treatment. So we're just going to have a pause here before we go on to the intraoral work and the final movement, which is the CV4 or compression of the fourth ventricle.